العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين Okay, I'm so sorry just now, just a little bit. Of okay, Ashraf, can you hear me?
Not just now, not clear, Hafiz. Whether it's your internet or my internet line.
I think my internet. Okay, I think without any delay, I would like to invite Prof. Nazri, Prof. Dr. Nazri, our Deputy Director of RMC, to give a few what I call talk. I would say that in this beginning to appreciate our program for today, inshallah. With that, I would like to welcome to Prof. Nazri.
Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Hafiz, for organizing this first talk, which is actually we have it regularly. I think we started about a few years ago. Initially, we joined with Kuliyyah Science and Allied Health Science, but it's we thought it's going to sunshine until the evening, but somehow it's rain in the noon, something like that. So alhamdulillah, we managed to proceed with, I think, a very good collaboration with al-Hikmah, which is the library. So hopefully with this collaboration, we can basically continue this program, which actually we want to make a research thing is very holistic and collaborative rather than very stereotype and narrow-minded. So basically, we hope that everybody from different Kuliyyah can listen, especially the young ones are very energetic. So we can continue to work together, interdisciplinary, interkuliyyah, and hopefully with the clinician also, so we can get input from each other. And I think atherosclerosis is very important because it was the most common cause of deaths, about 50 deaths per day in the mortality survey. But now COVID, more than atherosclerosis, now COVID, about 100 deaths per day, right? So for the last 10 years, I think heart disease caused death about 15 cases per day average. Whereas road traffic accident in my orthopedic things is about 20 deaths per day due to road traffic accident. So I think because Malaysian compared to other country is the most obese person in ASEAN. And now also the most COVID case in Asia. So I think with that introduction, I'm sure Dr. Ashraf will tell us more about this new research in atherosclerosis. Hopefully you all can benefit from this. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Okay, alhamdulillah. Thank you very much, Prof. Nazri, for the introduction. Okay, without delay, I would like to introduce my friends here. My friend here, Dr. Ashraf, Dr. Muhamad Ashraf Rostam, who is what I call his background. He is actually graduated from what I call RMIT from Australia, and then he worked on atherosclerosis and Proteoglycans and many more. And then I met him when in Australia, and then he has been publishing lots and lots of articles with a high impact, with high impact. And then if you can have a look to his Google Scholar, not only Google Scholar, I mean the citation index is I think among the highest between this our new lecturer in IIUM. So I would like to, with that, we can see how important is the study of atherosclerosis. And then I don't want to talk so much about about this. I would like to invite my friend here, Dr. Muhamad Ashraf Rostam, to give us some explanation within a couple of minutes, roughly about 30 minutes. And then on atherosclerosis and the sticky situation, the story of hyperelongated Proteoglycans. Following that, we will have a Q&A session, and then inshallah, we will end roughly about in 45 minutes or 1 hour of our discussion today. Without further much delay, Dr. Ashraf, please proceed. Thank you.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much to Dr. Hafiz and also Prof Nazri and the members from al-Hikmah for inviting me. Alhamdulillah for this session, which will start the Fast Talk series number 1, 2021. And hopefully we will try to make this program very beneficial to all. And I will try as much as possible, as similar how I've put the title, to be not too technical and somehow can be appreciated by all the members of the audience. And so if you can see the slide, it shows 72, but obviously I will not go to that much. I usually have that kind of way. I put all the slides after the thank you so that if there's any question, I will be able to address. But at the same time, I will acknowledge this, the 30-minute talk and not too technical, but hopefully it also can achieve one of the aims to inculcate more collaboration amongst us, whereby I have one particular slide showing that. At the same time, I'll be also allowing everyone to be able to appreciate this kind of information. So I will try to finish inshallah by 11:12. So I start at 10:42, so 30 minutes inshallah. So atherosclerosis and the sticky situation, I think sticky can somehow give a connotation of the stickiness, the melekat, or a very easy or layman term that shows kind of what happens in the heart when there is plaque formation. So the arterial wall becomes, there will be deposition of a plaque, which would narrow the intima or the kind of the diameter of the vessel wall itself, particularly at the arteries, and this would then slow down the heart. And what causes this stickiness? Yes, we know about cholesterol. I want to show what we can learn deeper into this, and this at the end can actually help us in formulating new therapeutic modalities or therapeutic approach. So I think yesterday RMC had shared to us IJN Foundation grant. I don't know whether this might be an avenue to open up for collaboration from the others. This particular research is on cardiovascular disease, and I hope that it might spark some ideas from other researchers in IIUM, and we might be able to think of something, inshallah. Now, at the end of this slide, I hope that you all can be still here to show you some of the potential collaborations with regards to this kind of topic and on these that are related to proteoglycan studies and atherosclerosis. Now we'll go into an introduction. So Prof Nazri has mentioned cardiovascular disease is the leading cause of mortality in Malaysia. Well, now it's down to number 2. COVID will be first. And one of the main risk factors is high cholesterol, hypertension, and diabetes. The NHMS study, the National Morbidity and Health Study conducted in 2019, the latest, we haven't still got the results, had shown that in Malaysia, 1.7 million, so that's quite high number or people have the 3 of the risk factors, including high cholesterol, diabetes, and hypertension. And the high cholesterol risk factor is the highest, well, obviously due to our lifestyle. And Prof. Nazri has mentioned that Malaysia has been coined as the most obese in Southeast Asia. And we can see here the data shows 4 in 10 of people or adults have risk cholesterol levels. So if at the moment we have 20 participants here, so if we times 10 people might have increased cholesterol level, and 80% of these people are on medication to lower down. Of them couldn't really manage or succeed to lower down. And these might be several factors. It's either the efficacy of the drug itself, which has been in several studies shown lack of efficiency in certain cases. I don't want to go into deeper in that. But at the same time, because of they fail to somehow change their lifestyle, which would complement the medication. And this, at the same time, with regard to the drug itself, we would then think of we'll be looking at one of the main options of drug development, the common ways of the development of drugs for atherosclerosis or cardiovascular disease has all been pushed into trying to lower the risk factor, which is it's either hypertension, diabetes, or the most direct is cholesterol. Most of the drugs, I'll go into deeper after this, but I'll try. I want to introduce to you that in this particular study, we will be looking at the targets to directly go into the problem itself, which is the vessel heart or arterial blood vessel becoming more stickier. Then if there's high cholesterol level, it would capture and retain that cholesterol. So this is actually a pre-inflammatory condition or stage. So before the process of inflammation and attachment of the LDL, and then later on the ones or the complications that we identify later. So if we fully understand this process of becoming stickier, we might be thinking of and do more research on targeting directly towards the blood vessel wall. So this might be one of the things that would be interesting, this particular type of research. So atherosclerosis, so this would be I'll be going through the 3 main stages of the development of atherosclerosis, and then we will go into detail on the pre-inflammatory stage. So as a background, I think I've mentioned about this. CVD is the leading cause of death in Malaysia, and most of this is due to the condition called atherosclerosis. Atherosclerosis is the formation of plaques. And if you can see here, this figure on here, I hope you can see my arrow here. I'm pointing on the healthy blood vessel shows a normal blood vessel without any plaque formation. But due to increase in fatty or cholesterol or lipid, hyperlipidemia, it causes a formation of plaque. So in a layman term, it's like a pipe that there's a lot of rubbish and somehow it's deposited in the plaque. Well, that can slow down that can increase actually the pressure. And at one point, if you imagine, then we'll take another example of a stream or a river. There's deposition of rubbish due to there's a trunks or ranting kayu at the river, on the sides of the river, and somehow that would then reduce or narrow the river itself. And imagine that at one time there's a banjir, there's a flood, and it pushes away that particular deposition, all the rubbish. And imagine that those rubbish goes to a shed or a narrower stream. And what happens, it can block that narrow stream and then prevent the water going to the other side of that blockage. And imagine that is happening inside our blood vessel. What happens is that blockage prevents blood from going to the other part. Hence, the parts that should initially receive blood now doesn't receive blood. So if this happens in our brain, it's called stroke. The arteries is called stroke. That's why we don't receive blood and oxygen. So a part of the cells dies. And in our heart, if that happens, usually in our arterial vessels that supplies blood to the heart, those parts of the blood wouldn't receive enough oxygen, so they die, and that's the reason why we have heart failure and so on. So that's kind of the analogy that I think we can imagine. So get rid of this rubbish and so on, and prevent this heart and becoming stickier. So you can see this is a real a cross section of an artery. So this dotted line shows what should have been a normal intima, and now it has been narrowed, and you can imagine how the high blood pressure that needs to go through this, and that's very dangerous. So this is kind of the overview in one figure showing. I'll show you another. This is from a paper, a very nice paper from our group also, previously in RMIT. But I'll show you one that I took from my thesis, just to differentiate or divide into three stages that is interesting. The first part is about pre-inflammatory stage. So LDL usually in the blood vessel is normal. The LDL will bring cholesterol. LDL is a type of cholesterol that we see, the bad cholesterol. Why? Because it brings from the heart, it brings the fat to the cells. Actually, for a good way, cholesterol is actually needed for our body to produce bile, steroid hormones, vitamin C's, and so on. But when there's an increase in amount, that is where it becomes deleterious, it becomes dangerous. So LDL is that form of lipid that brings all this cholesterol. HDL is the one that takes from our cells back to the liver. So we call it the good cholesterol. So LDL, normally in normal condition, you can just go in and outside of the. So imagine this is the lining. So the lining of our blood vessels can be divided into the intima and then the IEL, the media. So now in pathological conditions, when there's problems, the intima becomes, it increases in space. So we call it, it is now technically correct to be called neo-intima. Intima somehow has increased in space. And so the LDL should actually come in and go out. But unfortunately, when they are biglycans, proteoglycans are a part of the extracellular matrix that is inside our body. Nevertheless, if there is in pathological conditions, for example, there's oxidized LDL, they can become elongated. And this is the part where I'll be focusing on. And this hyperelongation, you imagine biglycans are normally, they are in a form of, they have two chains. So, well, you can imagine if the chain is higher or longer, it can trap these LDL particles. And when they trap these particles, they somehow, these LDLs can become oxidized. And now, if it's oxidized LDL, it is now in a condition where it is not normal to the body. And this would signal or stimulate our inflammatory response, saying that, oh, this is a foreign attack. And now it will call all the inflammatory response to come in. Macrophage comes in and tries to engulf these LDL. And nevertheless, these LDL, oxidized LDL, couldn't be degraded due to the nature of fatty components. And somehow it creates the foam cells, or we call it the foam cells. And these foam cells will be deposited, and later, eventually, in few years, it will start to collect, create calcification and buildup of cells, and to create a layer that is somehow it can be either stable, and that's the reason why there's that plaque itself, or in another condition, when that plaque builds up, it can be less stable. And when there's high blood pressure, it can push and it breaks, because calling it a condition of thrombosis. This is, as I mentioned earlier, about the analogy of the river, and this pushes and it can clog or block other downstream parts of our arterial vessels, smaller capillaries and so on. So a stable plaque is called angina. That's why people who have angina, they have discomfort in the chest, but an unstable plaque, it can break up and go down and clog other parts of our body. So this is kind of the overview, but so inflammatory process is the later part. So my study would be looking at this early part, where William and Tabas has coined this condition called the response to retention hypothesis. And this comes earlier, and we would be highlighting this so that we can find new avenues for treatment modalities. So this is why we call it the sticky situation. Due to hyperelongated biglycans, the structure that I've showed you earlier on. So what is the end in mind? What is the problem statement? I think I've mentioned and introduced a bit earlier. So the problem is most all the drugs has been addressing the lowering the risk factor, which is cholesterol. There's actually 4 types of drugs to reduce cholesterol by first reducing the absorption of cholesterol in the intestine. There's types of drugs whereby they reduce the production of endogenous cholesterol level inside the heart. So this is the famous statin trying to do that. And then there is also among the latest is the PCSK9, which tries to prevent from a degradation of LDL receptors in the heart, in the liver, whereby then it can recycle the receptors so that more LDL can be taken up by the liver and then be used back. So that is another type. And then, so now most of this is always about it. And there's the other one would be on cholesterol or inhibition of bile reuptake. So all of this comes back to the basic on lowering the risk factor, which is cholesterol. At the moment, there's not much trying to research on trying to target or address this sticky situation. So a new approach would be a vessel wall directed therapy. I don't want to go into detail about the statin war. This is the BMJ, British Medical Journal, and the Lancet. They've been talking about the statin, less efficacy, the side effects, and so on. But just to take the point that we would love to have more research and trying to find other avenues. Okay, it's 10:57. So now, atherosclerosis. So these are some of the research that had been looking at to show that well, this one is staining of the atherosclerosis, showing that lipid deposition. You can see that there's lipid is being stained at that particular moment. Macrophage is not being shown, so showing that inflammation hasn't shown up. But when we look back, that lipid and biglycan came along together. So they are co-localized prior to inflammatory response. So this is one of the elegant studies shown by Nakashima's group, showing that, so this further establishes the response to retention hypothesis, showing that yes, biglycan has been there earlier. That is the reason lipid is deposited, and why not looking a bit more into reducing this. So yeah. And another very elegant study published in Nature by Skalen. This was a team in Sweden, Boren's lab. So whereby they looked, they did an elegant study where they used genetic mic. So LDL is a transporter, obviously, and it can only enter the cells with apolipoprotein, specifically the APO100, ApoB100. And this is the one that binds and allows these LDLs to enter. Now, and this is also the kind of the mediator that attaches to the biglycans. The apolipoprotein has a positive charge, so you can see that it's an amino acid. So it has positive charge amino acids, and the biglycans has negative charge on its chain, and it would then retain this LDL. Now, what they did in that study is that they give that these fats or mice Western high-fat diet, so for about 20 weeks. So theoretically, in a normal condition, these rats would get obese, they would be hyperlipidemia and get atherosclerotic development. But they used transgenic mice whereby they mutated the ApoB, and it shows that they did not develop atherosclerotic lesions. That shows that yes, it is true that these LDL particles will require to be retained by this biglycan, hence would then reduce the development or prevent the development of atherosclerosis. So this was published in Nature. Now, from this, what we can see is that there is 3 different approaches to address this response to retention, either by modifying the lipoprotein, which has been shown here. So you can knock out that particular gene, you don't have the apolipoprotein, but well, in a practical approach, that wouldn't be good for a human being, obviously, because as I mentioned earlier, the LDL is required. It is actually something good to bring all this cholesterol. So that's something that we shouldn't be thinking of. Well, at the moment, if it's necessary, we can go deeper, but that's not the idea. The second is modification of the proteoglycan structure that hyperelongated. So that is something that we will be looking at. The third is trying to modify the interaction. I think if we can lesser the ionic interaction or so on, if that's possible, I don't know if there are some team from the chemistry department or so on, we can look into that. But the one that I'll be looking at is that we try to modify this proteoglycan structure, this particularly on the hyperelongation, which is the cause that causes increased binding to the proteoglycans. Now, the 3 major components of a biglycan structure, I've shown you that cartoon structure. Now it's in, this is a bit more of a technical kind of diagram. It should be in there's a core protein, there's a linkage region, and this I'll call it as a GAG chain, as a kind of abbreviation. This is the chondroitin sulfate chain that can elongate as much as it wants. And agonists and metabolic factors inside our body could increase or induce this hyperelongation. For example, the presence of oxidized LDL can induce this, can stimulate this. TGF-beta increase can also induce this. Other growth factors can increase in abnormality, can also induce this elongation. So it should not be in a normal condition. There is kind of the natural amount, but when it is being stimulated by all of these agonists, it can somehow become abnormally elongated. So this is the basic structure. So this is the natural or basal chain, and this is what we don't want, hyperelongation. And it has been shown that it is an additive effect. If we try to stimulate vascular smooth muscle cells and see whether it does show an addition by dose dependent. And if we add with other hormones, it shows that it is an additive effect. The studies show that it can increase. So now, why do we stimulate but with TGF-beta? TGF-beta has been shown by Bobic et al. This is a very good paper that studied in 21 participants who had atherosclerotic cells. Obviously, they took out and they showed that when they stained with anti-TGF-beta to show the presence of TGF-beta receptors, as well as the isoforms, there is increased in TGF-beta in these atherosclerotic lesions. So we can say that TGF-beta is highly involved in this particular development. Now, I don't want to go into this part, the development. So this is very much technical. All the enzymes that are involved to elongate. So this is actually one of my studies. I don't want to go, this is too much technical, but I studied all of that. Now, so this brings into the research of trying to find the therapeutic target. Now, if we're talking about the elongation, which part of the enzyme, which part of the amino acid, which of the sugar that we want to stop, because there's all sorts of targets. And even I forgot to mention that on the chain itself, the 2 ways, the elongation itself, we add to the sugar chain. At the same time, a sulfation adds to that negative charge. So, and there are enzymes that adds to that sulfation. So do we want to target the sulfation or so on? So what is the target that we're trying to see? Because we need to be more very specific on this. So this is a study by Imoto's lab. And Grani is the PhD student, actually an Indonesian. I would want to talk to her one day. So what they found out is that this is a very nice study. They looked at the aorta of the mice and stain about 8 weeks. There's an increase in staining showing that there's lipid deposition. And then the plaque area obviously increases. And analysis of that chondroitin sulfate chain after 8 weeks, they use this HPLC, size exclusion chromatography. There's a shift in the graph showing that there is a higher or longer molecular weight of that chain after 8 weeks. And this corresponds with increase in enzymes that adds to that to the elongation. So these enzymes that had significant increase was a sulfation enzyme, a polymerizing enzyme, the enzyme that puts this chondroitin synthase. This is significant, and this and other two enzymes. So I've showed you earlier that the slides I skipped. There's numerous enzymes. I think it was Izumikawa's lab that did a heavy study on all this kind of technical about this process of biochemistry. But what we want to know is that Angrani's lab or Imoto's lab found that these are the significant enzymes that had increase similar with increase in atherosclerotic development. So now we bring to another question. There is two different approaches to target this gap chain, where we've seen that these enzymes are involved. Should we mutate or target this enzyme itself? Now taking away all these enzymes by knocking it out, or the other approach is trying to find the signaling pathways, especially due to agonists that causes this increase in stimulating these enzyme elongation, and try to block these pathways. So we took the latter, where we try a bit more realistic, is try to find the signaling pathways, and then we explore whether we can find any targets in the kinases and so on to break that downstream chain. As opposed to trying to mutate the gap chain synthesis or the enzymes or the knockout, because what we need to know is that in a normal condition, a physiological condition, these enzymes are actually working and we require. So if we somehow take away that, in a normal condition, we are affecting all other places. Bioglycan is not just inside that vessel, it's part of the extracellular matrix. So you can't just take away these enzymes. So it needs to be specific due to specific agonist stimulation and so on. So the research hypothesis is now we want to find this signaling pathway that can be a therapeutic target, because we see that this pathway, TGF-beta as the agonist, could induce increased GAG synthesizing enzyme. We call it the hyperelongation of GAG chain, and that leads to increased LDL binding and eventually atherosclerosis. Now, the question will be to find this signaling pathway, which is actually a headache. And this is what I found, and we reported in our articles, which has sparked also quite a lot of interest. But we and the jigsaw finding all these signaling pathways, which I'll be showing, but very cursory overview. So this is kind of the mapping. TGF-beta has been shown by Bobbitt study. It is present in atherosclerotic development. But what we don't know is what are the kinases involved downstream. So we know that in any kind of TGF-beta signaling pathways, the kinases would be MEP kinase, GSK3, and so on. And the transcription factor that will communicate with our nucleus to increase the GAG chain is SMAD2 linker region, or SMAD2 transcription factor. So this is what we want to study. So my study then looked into, we took the idea from Angrani's lab but we used agonists of TGF-beta and we stimulated vascular smooth muscle cells. Specifically, we looked at saphenous vein and see whether there is a significant increase. And from the numerous cell enzymes, gene of the enzymes involved in that elongation, we showed that 4 of it, and it was consistent with Angrani's work in animal studies. TGF-beta, yes, it did show an increase in human cells from saphenous vein and in vitro experiments. So this particular sample came from a person who underwent a bypass surgery. So the saphenous vein was used and small parts of the cells were used from us. And we did this. So if you ask the question, why are we using veins? Whereby in our cells is arteries. Well, there's quite a lot of studies that have shown that the veins somehow, after even a bypass surgery, even though they use veins, specifically the saphenous vein, they are recurrence, whereby showing that the vein itself can show atherosclerotic development. So that's kind of a bit technical, but just to clear up things. I don't have much time, actually 1 minute, Dr. Hafiz. I'll try to just go very briefly. So then we went into all these studies on Western blotting and so on to find these, to map the kinases as I'm shown earlier. So this I'll go just very briefly, very fast because it's so much technical. And all this mostly enjoyed by people from this cell signaling kind of research. So I'll show you these are the enzymes that we found that were involved, some sulfation enzymes and so on. So the second aim, we mapped out the kinases involved. We did some SDS page. So these are kind of the questions that we asked. What were the specific residues on the linker region? And so these were genetic studies, specifically PCR and so on. I'll go through very briefly. And then this is Western blots to identify using inhibitors for that specific kinases. And finally, we get this kind of mapping. What are the kinases that somehow phosphorylates the specific residues on the SMAD transcription factor that then leads towards the increase in the specific enzymes that attaches or elongates the chain. So I published this in this paper from cellular signaling, and as well as this paper in pharmacology and therapeutics. And finally, the last part is about repurposed drugs. Can I get just 5 minutes for this? To very briefly, we should. Yeah, so we show that CDK is one of the kinases that was involved. And why this is very interesting is because CDK is mostly involved and more kind of established research of CDK is in cell proliferation, in cancer studies. So what we did is that we used drugs that had been gone through clinical trials to see whether it can work and try to kind of look into detail of which particular CDK is involved in this kind of signaling pathways. So, I've shown here that CDK is one of the kinases. It's popularly, if we learn science, it's kind of the gateway to transition from one phase of mitosis to another. And CDK inhibitors have been shown in these kind of applications, as well as cardiovascular disease. And this is kind of one of the CVP313, an inhibitor of CDK2 that was also being repurposed and tried to use on endothelial cells and other kind of inhibitors. And this is actually not latest. I haven't updated this, but these are some of the compounds of the CDK inhibitors that are now under clinical trials, and the ones that are in red is the ones that I've used in my research. And for example, palbociclib is actually now in the third phase of clinical trial. It has been aggressively being used for breast cancer. Previously, it was used in the first phase for non-Hodgkin's lymphoma. Now it's kind of getting much interest. So we also tested on this, and it targets the CDK4 and 6. So okay, so this is the overview as I shown you earlier. We can see that there's all of these kinases maps out to one of these residue, the serine 245, which then relates to this enzyme, the one of the chondroitin synthase enzyme, the other one is a sulfation. So we might bring this as a future direction to further kind of confirm this by doing knockout studies to see if, what if we knock out 245, and does this still happen, the gag elongation or not? If it doesn't happen, it then can further confirm that yes, it is inside the pathway. So and we might be able to try this and see as a therapeutic potential. So this is another paper that I reported all of this about flavopiridol, is the CDK drug that is very interesting, just to kind of tell that, oh, CDK is also involved in this biglycan studies. Why not we try to go deeper and think of this. Now, to bring to the discussion, as a summary, we have seen that there's increase in TGF-beta stimulation of these GAG synthesizing enzymes, and I've shown you the enzymes that is involved. SMAC linker region is a transcription factor that is involved, and they can be stimulated or phosphorylated, sorry, by all of these kinases, P38, PI3K, and so on. And understanding on the roles of CDK adds up to the vast knowledge of CDK's involvement in cell proliferation, and as well as cancer study. So we can somehow suggest that a combined drug of well, a CDK inhibitor or other drugs that needs to be well thought of can provide an efficient outcome. So it's this obviously needs more work to do, but it's something that we can work around. Why is repurposing drugs very trendy? Obviously, we know because those drugs had gone through FDA approval, at the very least for clinical trials. It shows that it's safe in humans, but it's yet there to be produced in public. So why not we can use this in other in vitro research first to test on other purposes. I think that if we understand this is kind of what's happening for the ivermectin drug, the hydroxychloroquine, all those anti-malarial drugs that were repurposed for COVID-19, and this is kind of not a shortcut, but it's kind of a way to expedite our research. So feature reduction, this is a bit detailed, but I think I've given some brief introduction. So I would like to end by acknowledgement to my Sifu, my teacher, Emeritus Professor Peter Little. So he's now the head of the School of Pharmacy, one of the best school in University of Queensland for pharmacy. He's a big teacher, and it's really actually sometimes very hard to be his student, to look to follow his very fast footsteps. And then, but he's very knowledgeable in this cardiovascular kind of research. He's been testing quite a few drugs and looking ways to find and improve pharmacology with regards to cardiovascular disease. And I acknowledge IIUM because most of this research is my PhD, and as well as the KPT. Potential collaborations. Should we bring this into discussion after this, Hafiz, or can I just start kick the ball running? I'll just
let's proceed.
Yeah. So before I pass to the Q&A, some of the potential collaborations. First, maybe what we can think of for those who are working on natural products, we might be able to stimulate, try to use vascular smooth muscle cell from a Malaysian patient, for example. We treat them with, say, oxidized LDL, which are pro-atherogenic, and then and test on GAG chain stimulation, whether it does induce elongation of GAG chain, and then inhibit with your preference of natural products. Then we can say that, oh, okay, this kind of drug, instead of my study that it shows that it can prevent atherosclerotic development, so it adds up to another kind of theoretical information that it does also involve in biglycan elongation, which is the pre-inflammatory stage. Epidemiological studies, we look at CVD patients, whether they have induced or nutrigenomics, whether they have whether they have their genetic makeup a higher kind of expression of certain genes that would elongate these change. I don't know. We might be able to see that. So take these CVD patients. Is there any kind of correlation? That would be kind of interesting. Ophthalmology, I've seen some studies actually from my team also. They looked at, there's this condition called EMD, acute macular degeneration, where that person, their view or vision in the middle is grayish. And one of the condition is because of deposition of fat inside the lining of the macula. And we have seen that in this case, it's not biglycan. There is other, I think it's other type of proteoglycan, but also there's hyperelongation, which then takes up or deposits this LDL, creating this deleterious effect, and then outcome is bad vision. So back to the story, these cases, the risk factor is increased. People with diabetes as well as hyperlipidemia. And now what we found is that, oh, okay, it's due to also relating to extracellular matrix for proteoglycans. Medical imaging, it might be trendy to see whether we try to inhibit GAG inhibitors and then see whether during the plaque development we can prevent from the production of these plaque in Western fat diet mice. So that would be kind of interesting to see. And especially looking at the stages, that would be interesting. Molecular studies, these are all about, these are kind of the personal collaboration with me. I might be able to collaborate in any kind of studies you want to see, gene expression, kind of kinase studies, phosphorylation to find the kinases and so on, and transcription factors. I would be glad to be involved in your study to do all this. And finally, maybe some matrix biology, any kind of disease that involves proteoglycans. I think there was one about a back pain. I was thinking about Dr. Yusuf, if he's involved here. I think I saw his name. Back pain, it has something relating to do with our lumbar, because obviously we've got a lot of extracellular matrix, and these conditions involved with disease of the ECM, and we might be able to do something on this to further understand the theories and understand behind this. Yes, that's it. I think. Thank you. This is just to promote my YouTube channel. I've also now kind of trying to go into a bit of a layman advocacy, trying to advocate about COVID-19 and some of the science communication to share with people, to allow not just knowledge being distributed amongst us academicians, but also to the public in a way of a more layman terms, and so that people can understand. Feel free to support and subscribe. I'll see you in my YouTube channel also. I think that's all. Thank you. Dr. Hafiz, we can open to maybe discussion. I would love to hear thoughts from you, additions, if there's a cardiologist or anybody here, any kind of background to further add to what has been studied. Thank you.
All right. Thank you very much, Dr. Ashraf, for what I call a very nice explanation. Okay. It's a very clear that I would say that this is something new, even though Dr. Ashraf has been conducted this research a few years ago. Yeah. Anyway, yeah, I think it would be great if we can open for Q&A from the audience. If you have any questions that you want to ask Dr. Ashraf in regards to the matter presented earlier. Okay, look, I have a question. Now, maybe it is not directly related to your research, okay? But when we look into the current situation, where in Malaysia, you can see that lots of people who, the diet is not, we have a very, we don't care whatever we eat. And then some of us do exercise, but some of us see that exercise can be a problem because not only because of the limitation of time, but also they see that, like the footballers, the Denmark footballers, suddenly collapse. And then you can see that some of the badminton players as well died a few days ago, if I'm not mistaken, Indonesian badminton players, and died because of heart attack. I just want to know whether is this any relationship between that kind of heart attack with this atherosclerosis?
Okay, thank you, Dr. Hafiz. That's a question I think I wouldn't be the best person to answer, but I have read a very interesting comment by Professor Dr. Azharisman, one of our esteemed colleague from the Kuliyyah of Medicine. He's now a cardiologist consultant cardiologist in KMC. And he wrote kind of an explanation, I think it's a bit of a layman and technical to answer this. And he mentioned this is a sudden attack. And yes, it's very interesting that it actually attacked those who are athletes, who somehow we can see very much active and doesn't suit the profile of people who have heart disease. So what he mentioned is about all of this is kind of the wiring or the electrical. Obviously, we know that the heart is of the pulse. You can say that it's electrical pulse that pumps up the blood and so on. Somehow he says that the layman term is kind of the wiring dia tak betul. And this can be several conditions and not necessarily just by the lifestyle and the diet, and it might be genetics and so on. So it's really hard for me to say whether it's due to this elongated, if that person has a plaque or not, because there are cases whereby the person, if we want to take into context of this deposition by glycans, there are certain cases that shows that is not a person that can have this condition doesn't have a kind of a bad condition of atherosclerotic plaque. So in that case, it's very much an interesting point to look into. But I don't have much information with regards to this particular response to retention hypothesis.
Okay, thank you very much, Dr. Ashraf, and my dear colleagues who joined us. Okay, there is a question by Dr. Fatin. Can this method be used to study the effectiveness of specific nutrients in healthy population, or to find the potential therapeutic benefit of specific functional food? Is it worthy practical to be done? So that's the question. Yeah, so that is very interesting question by Dr. Fatin, HUD for the Assessment Department of Nutrition. This is, I think, relates to one of the first point that I mentioned about the natural products. And actually, my Professor Peter Little, my mentor, they have started also looking at some of the flavonoids, particularly inside citrus. I think it's nitrogenine. I can't remember, but it's those flavonoids in relation to these the elongation of gag chain. I can't remember that people which particular target that they looked into. Was it the gag enzymes? Was it the chondroitin sulfate itself? I don't think it was in vivo study, but they have started to look into this. So from a perspective of a dietitian, of a nutritionist, as I mentioned, we might be able to see if you are working on a lay medical manuscript, you want to see and add to the information of these nutrients. It is something that worth to be studied. We can collaborate with those from the cardiology unit. We just want to take the vascular smooth muscle cells. I've used saphenous vein in previously because that kind of relates and the most in vitro kind of mimics the situation in the body. So that's the closest at the moment. We can try that if you want to look at human cells. We can also try in vivo, trying to see in animals whether this kind of method we try to block using
nutrients in. Oh, okay. You asked about healthy population, right? So a healthy population would be that would well, first I think in a study from the in vitro. Later on, yes, we can go into some of the human clinical trials. Let me just read again in detail. Used to study effect of nutrients in healthy population. Okay, so if you want to see whether this would be related to this can be in human population, I'll go back into the epidemiological studies. We can do some sort of retrospective people with a certain control group, those with CVD and certain types of diets. We can do sort of a correlation study. We map with some nutrigenomics, their genetic makeup, whether they have kind of increased in certain these genes that I've shown earlier. So, and then see whether there's correlation. Those with CVD are shown to have increase in GAG chain, enzyme that increases GAG chain, and those people who are active somehow doesn't have, or those certain who have kind of a certain a good or healthy nutritional practice don't have. So these are the things that might be thought of if you want to see epidemiological studies like this. I hope that answers the question for Dr. Fatin. Okay, and I want to further respond to this again, because I thought Dr. Hafiz would want to ask that, because some people say that with regards to familial hyperlipidemia, we see that certain people, they might be active, and somehow when they look at the cholesterol is too high, it's 7 and 8. Well, that's why we call it familial hyperlipidemia. It's genetics. And somehow, if we look, there are studies that show in certain cases, in certain regions, there are certain ethnics that has increased predisposition of cholesterol level, but they don't develop atherosclerosis. So can we say that their heart is less stickier? So that's a question that we want to see, and we might then be going back to the information about the response to retention hypothesis. So we want to see whether, oh, okay, they actually have cholesterol level high, but somehow the body doesn't capture the or deposit or retain these lipids. So that is the reason why it comes to different outcomes, because they ask, why is it that certain people where the risk factor is high, they don't get development of the plaque? Certain people who does have or even lower LDL, they do have. So these questions we can try to link back to the theory of response retention, and then maybe the way to address this is by genetic studies.
Okay, Ashraf, we have another question. This one is from Prof Zainul from Kulliyyah of Dentistry. Any specific natural product applicable to our country in this study? What would be your answer?
I haven't actually explored on natural product in our country, and specifically there hasn't much into response on this proteoglycan study. There's not much, and looking at this, there's in the literature to address this, whether it can. But obviously, I think what we may be able to take is any kind of studies that has ventured into looking into its effect towards prevent anti-atherogenic, and we might be able to further explore whether it does have earlier kind of function. With that, I don't know whether it might be whether it can go into a more of a preventive kind of approach instead of later on being used as a kind of a treatment after to address to lower the cholesterol level and so on. So it's something that I really don't know, don't have the information specific for that, but it's something the idea or the tips is by identifying the products that has been studied by Malaysian, looking at a specific product that can reduce previously they might report it reduces hyperlipidemia, but obviously that usually they will report as anti-atherogenic. So those are the drugs that we want to pick up, or sorry, the products that we want to pick up, and then we can further study, because once we understand this, it brings up to more ideas as a therapeutic option.
I do agree with what I call Prof. Zainul's question actually, because when Dr. Ashraf, when you say that so far you cannot, there is no like therapeutic or natural products, okay, that is suitable or suit to this problem. So maybe if we can find one, and then maybe who knows, in the future you can be one of the pengeluar utama for this kind of product. Anyway, thank you very much, Dr. Ashraf. We have been discussing for almost more than 1 hour. Okay, inshallah, next, on behalf of RMC and IIUM Kuantan Library, the Al-Hikmah, we would like to thanks to Dr. Ashraf, especially for the time he spent to share with us on his knowledge, what he has done during his PhD. Okay, and we hope that Dr. Ashraf will have more, I mean, all of us can work together, okay, with Dr. Ashraf, and inshallah we will try to, because what Dr. Ashraf has been doing throughout his study is very, very excellent, very, very, I would say that interesting, and then I think there are lots of things that we can do together to ensure that this project can be continued. Okay, if it is not at par as what they have done in Queensland University or maybe in RMIT, perhaps we can do at least some sort of thing like that, because we know that this is a very important problems. Atherosclerosis is not something that we can play around with. Yeah, okay. Next, inshallah, for the next month, we will have another speaker, Dr. Noratika Othman, and she is going to explain to us something that is also very interesting about bioinformatics. Any one of you who are interested to know more on bioinformatics, what she has done during her PhD, and then inshallah, I would like to invite all of you to join us and try to, I would also be appreciated if you can also invite other members to join the next session, inshallah, in 2 or 3 weeks. We will provide the announcement as soon as possible, inshallah. And I can see here we have not only professors, but also we have many assistant professors who joined us today. And I hope that we will have more and more sharing session like this in the future. So I think that's all. Thank you very much, Dr. Ashraf, and all the members. With that, let us end our discussion with the recitation of Tasbih Kafarah and Suratul Asr. Subhanakallahumma bihamdika ashhadu an la ilaha illa anta astaghfiruka wa atubu ilaik. Wal asri innal insana lafi khusr illa alladhina amanu wa amilus solihat wa tawassaw bil haqq. Thank you very much. Assalamu alaikum.